Hi everyone, I am Dr. Sagar Sahu and welcome to Vet Surgery at Ease. So today I welcome to another lecture in radiography pathology. We are continuing the radiography pathology of abdomen. We have already completed the liver, the peritoneal space, the spleen and also the urogenital system. Now today we will start from the digestive system, that is the stomach, then we will go for the small intestine, then the large intestine. Okay, so today we will be discussing all the pathologies, radiographic pathology, how they appear in the radiograph regarding the organ stomach. Okay, before going to the video, some formalities. If you are liking my content, the way I am delivering the lectures, do subscribe to the channel. That is very important. It helps me to grow actually. And also you can comment, okay, what are the improvements needed and which things you want. Like there are some comments regarding the thoracic radiograph abnormalities or radiographic pathology of thorax. I will do that just after finishing the abdomen radiograph. Okay, so you can follow me in Facebook, where I post the cases for pictorially. In the Instagram I post all these notes, the lectures which I am delivering. I am preparing the notes, handwritten notes. Those notes are posted in the Instagram. And also join the Telegram in the same name, Vet Surgery at Ease. There I post the PPTs as well as the notes in PDF format. And this is my Twitter handle. So this is the book which I am referring. Entire radiology has been referred from this book. This is very excellent book. If you want to study further beyond this lecture, you can follow this book. It may not be needed. I am trying to cover all those diseases, all those points, but still there is some portion which may not cover in this lecture. You can go through this book and you will find tremendous knowledge about radiography. So let us start the main topic, the stomach. So first some anatomy, which is also always needed. Okay, these are MRI pictures of sagittal section of abdomen of the stomach, abdomen of the dog, where the stomach is present. So this is dorsal ventral, this is left and right. Stomach is present in the left, mostly the fundus, body and the pylorus. These structures are usually visible. So important thing here to note is where the gas lies. Stomach contains gas as well as the fluid. Fluid has soft tissue opacity, so it is usually cannot be differentiated from nearby organs. But the gas, which has gas opacity, it can be visualized. So it is important while evaluating the stomach, because the gas plays an important role in diagnosing different diseases of the stomach. So in dorsoventral, if you are doing a dorsoventral radiograph, here you can see the picture really, okay, how the stomach lies. Here this is liver, these are liver, parts of liver. So the gas usually lies in the fundus when it is placed dorsoventrally, and the fluid will be present in pylorus. If I will simply rotate it, okay, dorsoventral to ventrodorsal, then the fundus will contain the fluid, which will have the soft tissue opacity. It means the fundus will not be easily visible in radiograph, but the pylorus and the body of the stomach will be visible because it contains gas. We will see the radiograph also. But note the anatomy. Similarly, if I will take the left lateral, simply I will rotate this one, okay, so that the fundus will be filled with fluid. Imagine, okay, I am rotating like this, pylorus will go up, due to gravity fluid will come into the fundus and the pylorus will be containing the gas. Okay, so in left lateral radiography you can evaluate the pylorus. If you want to evaluate the fundus, then simply do the opposite. Okay, simply do the opposite. When you will do the opposite, okay, the pylorus will be below and the fundus will be above. Okay, the fundus will contain gas and you can evaluate the fundus, but the pylorus will contain the fluid. We'll see the radiograph. Okay, simply imagine things, okay, how the anatomy is and how they will be positioned when we will be positioning the patient. Okay, let us see the radiograph so that it can be very clear. Imagine this picture. Okay, so this is the radiograph. So this is dorsoventral, this is ventrodorsal, this is left lateral and this is right lateral. Okay, so I told you in dorsoventral the fundus contains the gas, while the fluid portion will be in the pylorus. This is barium study actually. so that you can appreciate the what is the anatomy and how they are positioned. In the VD, you see the body, this is body of the stomach and this is the pylorus of the stomach. These two portions will be containing the gas. Okay, so now you can evaluate these two portions. If some foreign body or some pathology lies, you can easily evaluate. Similarly, in the left lateral, see the fundus contains the gas. This is this is pylorus. This is pylorus portion. This pylorus portion contains the gas, while the fundus contains the fluid in left lateral. When you will go for the right lateral, the fundus will be in dorsal side or towards the X-ray, and the pylorus will be towards the table. So the pylorus, due to gravity, will contain the fluid, which will have the soft tissue opacity. Here it is barium, that is why you can easily appreciate the pylorus. If it is not barium, simply survey radiograph, you may not appreciate this pylorus because of soft tissue opacity. Nearby there will be spleen and also the liver. This is the fundus, which contains the gas. Okay, so now you understood where the gas lies and where the fluid lies. It depends on the positioning and the view which you are taking the radiograph. Okay, so that is why usually while evaluating the GI system, mostly the stomach, you have to take 3 views at least: the left lateral, the right lateral and the ventrodorsal. Okay, so here see another radiograph. Here actually I wanted to show you the rugae, the rugal folds. Okay, so here you see some rugal folds. These whites are barium, and the filling defects, which is like radiolucent lines, those are actually the folds. These are actually the folds. Okay, in between the folds the barium lies. Okay, here you can see in a clear manner these radiolucent lines, these are folds, rugal folds. In between the folds there will be, this is barium. Okay, this is filling defect. Where the barium is not filled, that is known as filling defect. Those filling defects are actually the folds, while the filling things are between the folds. Okay, like the rugal fold will be like this, na? This is the fold. Okay, here there will be barium. So these two bariums, here we will find two barium. This is two barium. The fold will not contain any barium. So that is the filling defect. Okay, so that in that way you can find the rugal folds. Usually when they are not much distended, then you can find the rugal folds. If the stomach is adequately distended, you may not find the rugal folds. Here is another radiograph. Okay, this is left lateral view, this is right lateral view. Okay, I told you in the left lateral view, the pylorus will contain gas, the fundus will contain fluid. So fundus here, though you can say here is the fundus, actually you can slightly outline this one, but you can easily evaluate the pylorus. This is pylorus, okay, from which the duodenum is arising. Here in the right lateral, you see, you can appreciate the fundus here. Okay, due to nearby fat, you can easily visualize the fundus, but the fat in the abdomen, okay, not other circles. Due to that, you can easily visualize this pylorus, but the gas is present in the pylorus, the fundus. Okay, so this is very important while evaluating the stomach, where the fluid and gas lies. Importantly, the gas lies. Okay, if the gas lies in fundus, here you can see the gas lies in the fundus, so you can evaluate the fundus. And in right lateral view, in the left lateral view, we can evaluate the pylorus. Pylorus contains gas. Many times you may find some obstruction in pylorus. Most of the obstructions in dog and cat you will find in the pyloric region. So when you will take the right lateral radiograph, fluid will be in the right pylorus portion. So when the fluid will be in the pylorus, it will be having the soft tissue opacity. Suppose there is some non-metallic foreign bodies, so it will not be identified in the radiograph. Okay, so you have to take at least 2 views or 3 views to know whether there is some material or not. When the pylorus will be containing gas, it will provide a contrast. If some foreign body is there, it will provide some contrast, background contrast, so you can easily identify. Okay, that is the importance of taking multiple radiographs, especially in case of stomach or GI system. There are some differences between the dog and cat actually. This is dog stomach, this is cat stomach. The important differences is, you see, I am not actually discussing one point, that is gastric axis. I have already discussed the gastric axis in case of liver. Okay, in that video I will give the link in the description. You can watch their importance of gastric axis. So here if I will draw the gastric axis is drawn from the fundus to body to pylorus, okay, joining those. So when you will be joining a line, drawing a line, in case of dog it is usually perpendicular or near to perpendicular to this is spine, okay, nearly perpendicular to the spine. But in case of cat, if you will draw the line, it is usually makes a acute angle along to the spine. This is first difference. Second difference, you see usually cardia, fundus and body, they will lie to the left hand side and the pylorus here will lie into right hand side. But in case of cat, the pylorus is usually in the middle or nearer to the spine, okay, near to the midline. This is the second difference. Okay, these are basic difference between dog and cat. Okay, rugal folds usually they are not seen, but these two are the major differences between the dog and cat radiography. Next we will go for the contrast radiography. Okay, contrast can be positive contrast radiography, where you can use barium sulfate suspension, or you can use the iodinated contrast medium. When you will be using iodinated contrast medium, you have to give at the dose rate of 2 to 3 ml per kg. Okay, also you can do with the negative contrast. So when you will be using negative contrast, the media is usually room air. Okay, room air. The dose rate is usually 6 to 12 ml per kg. Okay, so mostly we will focus on a positive. Negative contrast is rarely used, specially used for detecting the gastric foreign body. Okay, negative contrast, that is known as pneumogastrography. Pneumo means air, pneumogastrography. Okay, it is very useful technique for detecting the gastric foreign bodies which are not radio opaque or slightly radiolucent. Okay, those through if the the x-rays pass, then it will not be visible. So for those, the pneumogastrography, we will provide the contrast and you can identify those foreign bodies. So we will discuss the contrast radiography, the procedure. Usually you have to make the animal fast for 12 to 24 hours. You can give enema for cleansing, then make barium sulfate suspension, then intubation is mandatory. You can also give through milk or some other edible food. Through food you can also give, but there is some problem. Sometimes they won't take, sometimes they will cough, it can enter into the respiratory system. So book suggests that you should go for intubation, which is a better thing. Then you have to distend the stomach, moderate distension, just like the urography. Okay, I have already discussed the urography in the urogenital system. Next, you have to gently turn the patient, so there will be uniform coating of the stomach. Then you have to take immediate views, the left lateral, the right lateral, the ventrodorsal and the dorsoventral view. Then you have to take 15 minutes, after 30, 45, 1 hour, 2 hour, 3 hour, 4 hour. Usually gastric is completely emptied in 1 to 4 hour in case of dog. That is normal. If it is beyond that, then there might be some obstruction. Or complete emptying the stomach. Up to complete emptying, you can take some radiographs at 1 hour interval in the latter phase. Okay, now this is positive contrast radiography, especially the barium sulfate. Here are some images of barium contrast study. I want to highlight where the gas lies. Okay, that is very important. You see left lateral, I told you in left lateral the fundus, the pylorus will contain the gas. See, here is the pylorus contains gas, here is the pylorus. Okay, and here also there is some gas under contrast also. Okay, in right lateral I told you the gas is present in the fundus. Okay, but here it is fully distended, that is why you cannot identify the gas. But after some time, when the gastric emptying will start, you can see the fundus contains gas. You can also appreciate the rugal folds here. Here also the fundus is completely emptied, all those materials are in pylorus, and you can very nicely see the rugal folds. Okay, This is ventrodorsal. In ventrodorsal, the body and the pylorus will contain the gas. You can appreciate here. Okay, here also, here the body and the pylorus. Here the complete emptying was there. So all the cardia also they don't they contain the gas. Similarly, dorsoventral you will find the fundus. Okay, here you can see the fundus. Those fundus contain gas, not the pylorus. In pylorus there is contrast material. So it is very important that you should know where the gas lies and where the fluid lies. So the gastric emptying, some data, usually it starts within 15 minutes, but it depends on the dog's psychological conditions also some diseases whatever there. But suppose in a case it starts at let us assume at 30 minutes, but then it went normally. It is complete emptying was there up to 1 to 4 hours. Suppose 2 hours, then it is normal. There may be some initial delay, but it is emptying in normal time, then it is fine. Okay, but when the emptying is prolonged, then there might be some disease. Okay, so in dogs the study shows that the normal gastric emptying time is 1 to 4 hours, but it may slightly vary. Okay, so next we will go some diseases. First disease is the hiatal hernia. The normal anatomy part is now over. Let us go to diseases. So the hiatal hernia, some theory, it is 3 types. Okay, the type 1, then the type 2, type 3. Okay, the type 1 is known as sliding hernia. In this hernia you will find the content to be the stomach, part of the stomach as well as the esophagus. Okay, so these are the contents. Next, in type 2, which is known as paraesophageal hernia. Okay, in this only the stomach will be herniated. Okay, but it's usually you will find the fundus part will be herniated. Type 3 is a mixture of 1 and 2. Okay, mixture of 1 and 2. Most commonly you will find this sliding hernia. Most commonly in case of dogs you will find the sliding hernia to be most common. Okay, so I told you the types, but I have not told you the definition. So the hiatal hernia means there is a defect present in the esophageal hiatus. It is present in the diaphragm, esophageal hiatus. Okay, there is some defects. Through these defects, the abdominal contents will migrate cranially. Okay, so cranial migration of the abdominal contents through the defect in the esophageal hiatus is known as hiatal hernia. Okay, so this is right lateral, this is left lateral. Okay, and this is also left lateral. What is the difference? This is right lateral. I told you the fundus will contain the gas. Here you can see this is the fundus. This is left lateral. The pylorus contains the gas. Here is the pylorus. Okay, but see here. This is one crura. In the left lateral, the cranial one is the left crura. This is right crura. Okay, diaphragm have 2 cruras. I have already discussed how to differentiate between these cruras, and also by looking at these cruras you can tell whether this is left lateral or the right lateral. Can you see a soft tissue structure here? Okay, there is a soft tissue structure here. There is a margin. Okay, see, I told you the sliding hernia is very common. As the name suggests, is a sliding hernia. Many times while taking the radiographs, it may be in the normal position. Okay, because stomach lies with the left crura. Okay, it touches the left crura. So you may not diagnose this condition as a hiatal hernia. Okay, so what to do? In this book discussing regarding this case, at this very time the dog actually coughed. When coughed, just after the cough, when the radiograph was taken left lateral, you can clearly see a soft tissue opacity at the caudodorsal thorax. Caudodorsal. So this region you can see this soft tissue opacity. This It means the stomach has herniated into the through the esophageal hiatus. Okay, so the technique is, if you are suspecting from hiatal hernia like that, you have to increase the abdominal pressure. When you will increase the abdominal pressure like cough, or you can manually increase the abdominal pressure, then only it will herniate and you can identify this as hiatal hernia. Okay, here is the duodenum. Okay, this is duodenum. Okay, understood the hiatal hernia. Next we will go for the peritoneal pericardial diaphragmatic hernia. Okay, this is a congenital condition and a very rare condition. Okay, congenital as well as very rare condition. If you are getting the case, you may win a gold medal in some conference. Okay, so in this case there is some connection between the pericardium and the abdomen. Okay, so usually the radiography finding here, you will find a large cardiac silhouette first. Second, you will find the codo-ventral silhouette of the heart, like here. This is codo-ventral silhouette heart. There is no distinction between this silhouette and the diaphragm. Can you differentiate between these two? You cannot differentiate. It is like it is continuous. Okay, so in this is dorsoventral, sorry, ventrodorsal. You can see is the stomach into the thorax. Usually it is into the pericardial sac. Okay, so this is very rare condition. If you are finding, you may not find, but you should know that this condition can exist. This is congenital and very rare condition. It is, in short form, it is known as PPDS. Okay, peritoneal pericardial diaphragmatic hernia. Next, pylogastric intussusception. This is also a rare disease or uncommon disease, you can commonly say. The uncommon disease. This disease has been reported in dogs. Okay, but still it has not been reported in cats. Okay, so what is intussusception? You know that. Okay, so sorry, this is right lateral, this is left lateral, and this is ventrodorsal view. See here, when taking right lateral, usually in right lateral you will find fundus containing gas. So when there will be intussusception, there might be fluid accumulation in entire stomach. So in right lateral you may not appreciate the fundus because of presence of fluid. Okay, here though you can identify some gas margins are there, you can identify the fundus. When taken in the left lateral view, see the pylorus contains the gas, but you can appreciate this is intussusception. This is characteristically taken. This is the lumen actually. Okay, this is the lumen, this lumen. Okay, some portion is there. Okay, so when you will take the ventrodorsal, the characteristic radiographic sign is, you will find a soft tissue mass or a soft tissue opacity arising from the pylorus. Okay, through the antrum and the body, it is will be projecting into the stomach or the body of the stomach, or sometimes it will go up to the fundus. Can you see this one? Okay, so this is basically intussusception of the pylogastric intussusception, but it is the invagination of pylorus. This is contrast radiography, pneumogastrography. Air has been given so that you can see one interesting thing. Usually pylorus lies ventrally. Okay, it is in the right side and in ventral, but here it is in the dorsal side. How this happened? Okay, due to the over distension during the pneumogastrography, the stomach was overly distended. Okay, so it goes up. I will discuss the gastric dilatation and volvulus. There I will discuss the concept how it actually rotates and how in the radiography it is found in dorsal position. Okay, just know for here. So this is the pneumogastrography. The stomach is highly distended and you can find a ball here, but in case of lateral view, you can see this is actually the fundus or body of the stomach. Sometimes you may not differentiate between the body and fundus. Mostly it will be the body of the fundus. Okay, they are nearly same. Okay, in level exactly you can't tell where is the body, where is the fundus, but like that. And this is the actually pylorus. You can see the pylorus is projecting into the body of the stomach, and you can see clearly it is the invagination. Okay, this is intussusception. I will discuss why the pylorus went up dorsal. Next is acute gastric dilatation. This is nothing much, simply the stomach is dilated. This is a radiography of cat. How can you say this is a radiography of cat? See the fat here. Okay, it is liver is slightly above from the abdomen margin. Okay, this is fat, falciform fat. Okay, in case of cat, I have already discussed in normal radiography. Okay, so you can check that. I will give the link in the description. So this is simply distension of the stomach, nothing much. Okay, sometimes usually stomach lies inside the cage, the thoracic cage. Sometimes if it is beyond that, you may tell that it may be dilated, but stomach is highly mobile organ and a highly stretchable organ also. So you may not go into direct conclusion that it is distended. Okay, sometimes due to fasting it might be slightly gas filled and it might be slightly dilated, but the thing is there is dilation, gastric dilation, but it may not be pathological. But this gastric dilatation, when not corrected, it may go to gastric dilatation and volvulus. How it happens? Okay, listen carefully. Okay, how this happens? So this is left side, this is right side, this is dorsal side, and this is ventral side. Okay, so here is the fundus. This is fundus. This part is usually fundus, then the body. Let us assume entire thing to be fundus. Okay, it will be very easy to see. This is ventral, this is right. So fundus is right and dorsal. This fundus is right to the right side. I am very sorry. This is left, this is right. I mistakenly wrote that's right. So this fundus is in the left and the dorsal, while the pylorus, this is pylorus, is ventral and towards the right. So when there will be gas accumulation, continuously there will be gas accumulation, the pylorus will go up and it will slightly rotate. Okay, while rotation, notice the diagrams. Okay, I got it from the internet. This is very good diagram. So when it will rotate, now see, this is actually the fundus. Now sorry, this one is the fundus, this one is the right side, this one is the left side, this is the dorsal side, this is ventral side. Okay, this is the fundus is now in right and ventral, where the pylorus should lie, and the pylorus is in dorsal and in left side, where the fundus should lie. Now why I told you that? So that you can say where the gas and fluid will lie in the radiograph. Here if you want to evaluate the pylorus, here the pylorus will not be visible in left lateral view, it will be visible in the right lateral view. Okay, simply the reverse. While if you want to evaluate the fundus, you may not get in the left lateral view, right lateral view, will evaluate in left lateral. But in gastric dilation and volvulus, usually the fluid portion will be very less. Mostly it will contain gas, so you may evaluate in both the views, but you should remember the concept. If at all there will be fluid accumulation, then you can tell that in which view you can evaluate which side. Okay, let us see the radiograph so that you can appreciate. So this is the radiograph. This is left lateral view, this is right lateral view. Okay, so in left lateral, what you are seeing here is not the pylorus, this is the body. Okay, body of the stomach. Body and fundus usually you can use synonymously, but anatomically they are different. So this is the stomach, body of the stomach. Here the pylorus is not visible. Okay, but you can see the stomach is distended. Okay, here the entire stomach is distended. Here it contains fluid, but when you will take right lateral, this is pylorus, this is body. Let me draw it for you. This is the entire stomach. Here is the compartmentalization. Okay, this is known as compartmentalization. This is pylorus, this is body. This is very much characteristic for the gastric dilatation and volvulus. So while you are getting a case, at least take two views so that you can identify the gastric dilatation and volvulus. The compartmentalization, which is usually found in right lateral radiograph, is the characteristic feature for the gastric dilatation and volvulus. One more thing, see the spleen. Spleen is usually, it will, and there is some part is lost, it will be C shape or U shape like that. That is also consistent with gastric dilatation and volvulus. I have already discussed the spleen, rotation of the spleen, which is usually associated with the gastric dilatation and the volvulus. Okay, so that also I have covered in the liver peritoneal space and the spleen lecture. If you want, you can also check the link in the description. Okay, so this is gastric dilatation and the volvulus. Just remember the concept. When you will remember the concept, you can find anything in the radiograph. This usually, another thing, usually the rotation is 180 degree. Okay, usually you will find 180 degree or slightly less than that much of rotation. 300, if the rotation will be 360, suppose this will be usually 180, okay, it is rotated 180 degree. If it will be 360, what will happen? You will find the pylorus to be normal and the fundus normal in the normal anatomical position. Okay, so this is very rare. Okay, but there is a photo in the book, very nice photo. This is 360 degree rotation. So when there will be 360 degree rotation, usually the gastric tube you cannot enter to the stomach. Okay, because of high rotation. Okay, in 180 degree you may be able to pass the gastric tube, but here you may not be able to pass the gastric tube. Okay, but usually they are diagnosed in the exploratory laboratory. So here this is left lateral, this is right lateral. Very much characteristics. Left lateral you can identify the pylorus here, but in right lateral you cannot identify the pylorus. This is simply the body. Okay, this is the body of the body and fundus of the stomach. Here this is body and fundus. Okay, the accumulation of gas. There is no fluid at all. Okay, so here you will identify the left lateral view, the pylorus. Okay, this is normal because of 360 degree rotation. Okay, understood? Next we will go to the chronic pyloric obstruction. So the pyloric obstruction can be due to many causes. Okay, maybe due to pyloric spasm or mucosal disease, like that, many things. So in pyloric obstruction you will find two things in what you will find in survey radiograph and what you will find in the contrast radiograph. So in case of survey radiograph, only you will find gastric dilatation. Okay, and here in acute gastric dilatation you will find gas to be predominant over the fluids, but in case of chronic pyloric obstruction, in case of survey radiograph, you will find fluid to be predominant than gas. That is why you will find the stomach here. The stomach is highly enlarged or distended, you can say, but it is of fluid opacity, mostly fluid. You will find some gas here. This is pylorus from which the duodenum is arising. Okay, so it is fluid. This is dorsoventral view, sorry, ventral dorsal view. See here. Okay, it is distended, but it is of soft tissue opacity. Okay, understood? So this is the difference between the pyloric obstruction and acute gastric dilatation. Now let us go to the contrast. What you will find in contrast? So in case of contrast, you have to do the, I told you, gastric emptying test. Okay, you have to take 15, 35 minutes, 45 minutes, like that, 1 hour, 2 hour and 3 hour. This is radiograph was taken 10 hour after feeding the barium. Okay, still there is some barium left. One thing is stomach is enlarged and you can find the barium here. Still contrast agent is present. That means the gastric contents are not emptying naturally or normal. So there is some pathology line. It is mostly due to the pyloric obstruction. There are some signs also. You should know that 3 type of sign you may find in pyloric obstruction: the string sign, the big sign and the teeth sign. So what is string sign? Let me draw things for you so that you can understand. So this is stomach. So this is pylorus. Okay. So what is string sign? Suppose something is obstructing. Okay. Suppose something is obstructing. So this much it has been obstructed. So when barium will line this one, there will be thin string going. This is string sign. Here you can see very thin lining. This is string sign. Okay. So what is big sign? When the obstruction is nearly complete. Okay, nearly complete. So the barium which lie, it will have something like big. Understood? Okay, this is big sign. There is not photograph of big sign, but you can understand from the picture. Next is what is teeth sign. Many times what will happen in pyloric obstruction, you will find neoplasia. Suppose there is some pyloric neoplasia here lies like this. There is some neoplasia. You know that there is will be peristaltic movement of the stomach. Okay, so now entire content, the white part which I have not colored, it's barium. So when there will be peristaltic movement, it will come like this, like this, like this. When it will reach here, due to the obstruction by some neoplasia or some structure, what will happen? This layer will outpouch like this due to the continuous pressure by the peristaltic movement. So this pouch is known as teeth sign. Here this is pouching, this is teeth sign. Usually it sign denote that some neoplasia or some big mass like structure is obstructing the thing, and this is teeth sign. Okay, understood? What are these signs? These signs are related with the chronic pyloric obstruction disease. Okay. Next, we'll go for the gastric foreign body, which is very common. Most of the radiographs in clinical complexes is taken for this one also. Okay, sometimes the owner will complain, my dog ate some ball, my dog ate some towel, my dog ate some fish hook or nail, anything. Okay, so the gastric foreign body can be metallic or non-metallic. Usually metallic is very easy to find. Okay, like here the dog has eaten some coin. Okay, it is very easy to find. There you need not to worry. The thing of worry is usually the which are radiolucent, okay, or less radiolucent. Sometimes the gas inside the stomach provides the contrast. Here the gas in the stomach provides contrast. You can identify the foreign body. Okay, this is lateral view, this is the ventrodorsal view. You can identify the foreign body. Okay, so many a times you may not find the foreign body because of their radiolucency. So what will happen? Sometimes, though you can identify here in this particular radiograph, you can identify here, you can identify here, okay, this is a foreign body, you can identify, okay, but sometimes some material you may not actually identify because of presence of fluid as well as the material. They will have same opacity and may not appreciate. For those cases you can go for pneumogastrography. Okay, pneumogastrography, this is a very cheap method actually. You don't need any special equipment. Pneumogastrography, this is a gastric tube which is passing here. Okay, this is a gastric tube through which the air has been infused, and in this air provides contrast, and you can identify the foreign body is in much better way. Okay. Or apart from pneumogastrography, there are also some other techniques, like the very easy one is taking radiograph in different positions. Okay, so that taking radiograph in different positions. Okay, so you have to turn the patient in different views. Okay, so that the fluid and gas can intermingle between them. Okay, sometimes the foreign body will be at the gas region, so that you can easily identify. So you have to take different views by turning the patient, or you can go for low barium contrast. Okay, here you don't need full dose of barium, you can go for low dose so that it can outline the foreign body, low barium contrast. Okay, so these two are the techniques through which you can identify the foreign bodies which are not radio opaque. Okay, so these are gastric foreign bodies. Next we'll go for gastric ulcers. See, gastric ulcer is two types. One is benign gastric ulcer, another is malignant. The benign ones are known as peptic ulcers. Both benign and malignant ulcers cannot be identified in survey radiographs. You have to do for contrast. In contrast also, these peptic ulcers is usually not diagnosed. This peptic ulcer, the common cause is NSAID administration, long-term NSAID, non-steroidal anti-inflammatory drug administration. Okay, but you can identify this malignant ulcer. They are usually associated with gastric neoplasia. Very commonly found with gastric neoplasia. What will happen? There will be some tumor and there will be tumor necrosis after some time. Those necrosed part will create ulcer, that is the stomach ulcer, stomach tumor, and then they will go into the ulcer, stomach ulcer. So what are the radiography features of gastric ulcer? The best radiographic is there will be outpouching and with crates. These are crates. Okay, so this is outpouching. It means this is the ulcer point. Remember, sometimes you may get confused with the peristaltic movement. So we have to take subsequent. Usually, when you will be taking the barium radiograph, you have to take subsequent radiographs at some intervals. So at each radiograph, this should be present. Okay, if it is not present, it may be due to peristaltic movement. Okay, that is how you can differentiate between them. So this is the gastric ulcer. You can also go for ultrasonography for this one. But usually the presence of gas sometimes hinders the ultrasonography, but you can go for ultrasonography. Next is gastric neoplasia. This is the last disease also, gastric neoplasia. What will happen in gastric neoplasia? You will find filling defects. Okay, those neoplasia part you may not find any barium contrast occupying it. So you will find the filling defects. So the gastric neoplasia is very common in pyloric portion rather than other portion of the stomach. Okay, pyloric portion. They are usually polyps. Most commonly you will find polyps. So here this is a radiograph. You can see some defect here. Okay, normally it should have gone like this or like this. Some defect is here. It might be some polyp. Okay, and here you can see here is some defect. Okay, here is some defect and here is some defect. Okay, so you have to take subsequent radiograph to identify that this defect are there or not. Okay, if it is not and it has come to here, then maybe it is peristaltic movement. Okay, next another image of this gastric neoplasia. See here, very nicely you can see this one. This is a tumor mass actually. Okay, this is the filling defect. Okay, and can you see the string sign? This is pylorus. Okay, going to this is duodenum. The string sign. There is pyloric obstruction due to this neoplasia. Okay, this is the mass. So this is all about the stomach and the diseases of the stomach that can be viewed radiographically. So next we will go for the radiography pathology of the small intestines. So if you like this content, do subscribe to the channel and also share with your friends and juniors and seniors and colleagues, whoever you may find. Okay, so until we meet in the next class, till then, tata, bye bye, take care.